Okay, and we're live, looks like. All right, good morning, everyone. Does anybody have any questions for me? Any questions on anything we've gone over? No? All right, class going okay for everyone? All right. This is our last week, so we only have one class after today. Good morning. So our last class will be on Wednesday. You'll need to bring your yellow book back. The spiral book is yours to keep forever, but you'll bring your yellow book back. We also will take a class photo, and employers often look at those photos. So if you're here, it's, good to be in the photo. I don't tag anybody, so I won't put your name in. You'll have to go share it yourself or tag yourself, okay? Does that sound good? I don't know who's in the witness protection program, so. All right. Wednesday, there's still a lot of information to go over. Today, we're going to cover the last 3 skills that we have to learn. But Wednesday, we have a lot of other information to go over, things like how to renew your certification, what is continuing education and how do you get it, how much do you need, what happens if you don't get it. We're going to talk about employability, things like how to find a job in healthcare because it's different than other industries. It doesn't follow the same go on an online jobs board and look up for openings. That's not really how medicine works for employment. So we want to go over some different strategies for finding employment in healthcare, and I'll explain why. But probably the most important part of Wednesday is, when you're going in an interview and they ask you that question that everybody hates, tell me a little bit about yourself, right? Nobody likes that question and everybody freezes. What do I say? So I'm actually going to give you a formula that you can use for you specifically to tailor your response based on your previous job, your characteristics and everything. There's a formula you can use, and it's kind of like playing Mad Libs. It's a lot of fun to craft your own, but I'm going to give that to you on Wednesday. And this is good for any industry, by the way. It's not specific to healthcare. So it's just a really good way of crafting your tell me a little bit about yourself speech. If you go in with a little bit of confidence and you're well prepared with your speech, you have a much greater chance of getting the job because it shows that you know what to expect, you know how to prepare, which means when you get on the job, you'll be able to prepare. You'll be a step ahead. Does that make sense? Do you understand how that comes across? Remember that CNAs are charged with communicating with patients, right? And families. It's part of what we do. In fact, socialization is one of the ADLs that we're responsible for. So it's good to know how to be in situations that are uncomfortable for you, but still be able to communicate effectively. And that's really what they're grading you on or judging you on during the interview, is your ability to communicate under pressure, because it's a big part of the job. Does that make sense? So we're going to go over all of that on Wednesday. So that's not a class you want to skip. It's very, very important. Getting your certification is one thing, keeping it is another. So that will take about an hour and a half on Wednesday. The rest of Wednesday you'll have for practice. Today you're probably going to have about an hour and a half of practice as well, depending on how quickly I can get through the lessons. We only have 4 skills to learn, the 3 that's on the syllabus, and then we're going to do range of motion shoulder, which we didn't get to earlier in the program. So there's not a whole lot here to learn. Everything we're going to learn is basically recycling something else that we've learned previously. Okay. So nothing really hard today. Good morning and good afternoon, everybody. Oh, wow. Yasmin is watching from the UAE. So welcome. Welcome. Yeah, we have an international audience. United Arab Emirates. Yeah, the Middle East. Yeah. A lot of uncertainty going on in the Middle East right now. So we send good vibes out to you. All right. We're going to go ahead and get the scores for chapters 8 and 9. And then you only have one more chapter to do between now and Wednesday. But let me get your scores for 8 and 9. Isabella, Kiana, Julia, Jay. Okay, it's fine. Erica, Sophia, Victoria. Thank you. Christine, Cleonta. Thank you. Autumn. Thank you. Chloe. Do you have 7 for me as well? Thank you. Adriana. Thomas. Lisette. Thank you. Lisette, can I get 5, 6, and 7 from you? 85, 85, 90. Thank you. Janae? Jamar? Thank you. And Celeth? Thank you. Celeth, can I get 4 through 7 as well? 6? 5? And 4. Thank you. All right. Any questions on that so far? Everybody good with what we've gone over? Last class. If you have not registered for the test yet, you should. You're ready. You are. I know you don't feel like it, but you are. Okay. You won't realize how ready you are until you go to test. You can register anytime. So you can either do the online registration, which is the paper that I gave you, but just on the computer screen. That's your fastest option. Or you can mail in that whole packet that I gave you. Either way is fine. Did you do your background check yet? You'll want to do your background check before you register. Okay. Game show tomorrow. And the game show is going to be on providing care for residents with specific health needs. So basically, it's going to focus on what kind of care we should provide for somebody with Parkinson's. So it's going to gauge, do you know a little bit about Parkinson's? Do you know a little bit about diabetes? Do you know a little bit about how to care for somebody with a hearing impairment or a vision impairment? So these are all the types of questions you would find under the category providing care for patients with specialized needs. But that section also goes over how to care for people with psychological needs like depression or anxiety or mental health deficiencies or disabilities and things like that. So I want to spend just a minute talking about that topic because it's going to be relevant to tomorrow's game show, but also because I want to give you a perspective that you probably don't have about some of your patients. Okay. So to understand this, we're going to talk about Martha. Now, Martha lived across the street in the big housing community. She and her husband, Frank, retired from New Jersey, came to Florida, were very, very active. had a little golf cart, went everywhere, was active in tennis and different clubs and things like that. And then Frank passed away. Now, this was a real problem for Martha because she didn't drive. Up in New Jersey, she took public transportation everywhere. And her husband did all the driving down here. So she is now widowed with no transportation. So she enrolls in a driving class and she gets her license. And it's a little iffy because she's in her 80s and her reaction time isn't as strong as it could be. And she gets easily flustered, but she is able to drive enough to get to her doctor's office and the grocery store, which has a pharmacy, to get her medications. So she's able to pretty much take care of herself. But she gets into little fender benders here and there because she gets flustered. And, you know, unfortunately, people on 19 are in a big hurry and she's not. So she has a few fender benders. And then she goes to the doctor one day. And the doctor gives her some very distressing health news, and she's really flustered. And instead of putting it in reverse to back out, she puts it in drive and goes into the building. So her car insurance is now canceled. She was fine, spent one night in the hospital. They discharged her. And she called her daughter and said, I need help. I can't do this alone anymore. And the daughter says, well, why don't you move up here with me, Mom, and we'll take care of you. And she said, no, I can't handle the cold anymore. What do we know about that? Why can't she handle the cold anymore? Yeah, she's lost that subcutaneous fat. That's right. So the daughter says, well, Mom, I can't move down there. I got kids in school. I got my job. I can't move down there. What are we going to do? So the daughter says, let me think about this and I'll come down next weekend and we'll talk about it. So the daughter flies in on Thursday and takes her mom out to lunch and said, all right, Mom, listen, I talked to my brothers and this is what we've come up with. You're going to have to go into an assisted living facility. Since you can't come up there and we can't move down here, it's the only option available to you. You can't drive. And this community is not set up for people that can't drive. So you're going to have to move into assisted living facility. And the only way that we can pay for it is to sell your house. So I've got a realtor coming at 5:00 and we're going to put the house on the market. And houses are moving quick. So I expect it's probably going to sell pretty quickly. So tomorrow you've got to get everything out of the house that you don't want. You can only take 2 suitcases full of items with you to the assisted living facility. That's it. And you can't afford a private room. So we've got a semi-private room. I found a really nice assisted living facility for you, but you will have to have a roommate. And you don't get to pick the roommate, but I'm sure it'll be a lovely person. But the real problem here is Sadie, your dog, because you can't take the dog with you. And I know that you've had Sadie for 11 years, but she's going to have to go to the ASPCA. There's no way around it. And, you know, and all of this has to be done before Sunday because I have to fly out. I got a work presentation on Monday. So, good morning. So here Martha is in your facility. And she didn't get there because she wanted to sign up. She got there because life circumstances happen. And for her to be there, she has lost her home, her possessions, her pet, her independence. And then her family just left because they have a life somewhere else. So what do you think Martha's state of mind is? Oh, horribly depressed. She probably isn't. What's that?
She wants to die.
Yes, she wants to die. Yes. She's probably wondering, why am I still here? What good is this? I'm just, spending all my kids' money by hanging on. And this is the mindset of a lot of the patients that you're going to be dealing with. They're going to be depressed. They're going to be angry. I would be angry. Do you think when she was working that this is what she had in mind for her retirement? No. So angry. is probably an appropriate reaction. Frustrated because she had to sell her house to move into this facility and you won't even answer the call lights. So when we think about patients, we have to stop and think about their psychological state as well as their physiological state, because the psychological state will affect their health. So we have to think about things like depression and anxiety and anger. There's part of the grieving process. You know, when you lose a pet or lose a family member, you go through a grieving process. And there's 5 stages to grieving. You don't go through them all in a specific order, but there's usually anger and bargaining and depression and denial and acceptance, you know, and you may flow in and out of each one of those. My father passed away about 6 years ago, and my mother had a very weepy day yesterday, and it just hit her out of the blue. Nothing triggered it. She just woke up sad that he wasn't there, and she cried. Grief is something that doesn't ever go away. You don't start it, move through it, and end it. But you grieve every loss in your life. You grieve losing a job. You grieve losing a family member. You grieve losing a house when you move. You grieve every loss in your life. But let's look at Martha. How many losses did she have all at once? A lot. And that would really affect anybody's ability to move through life successfully. Does that make sense? So we need to make sure that we understand where they're coming from, and we employ a lot of patience and a lot of encouragement. So psychological difficulties is very relevant to what we do. And that's why you're going to have some questions on the state exam about that. Does that make sense? So you'll have some questions about the grieving process. You may have a question about post-mortem care, which is care of the dying or dead individual once they progress through the dying process. We don't expect you to do post-mortem care right out of CNA school. Yeah, you will have to shadow somebody else that's doing it to kind of learn how. The biggest thing to remember is you are the last caring hands that will ever touch that human body. So how do you want to send them off? That's the biggest thing you need to know about postmortem care. It should be done gently, with great reverence, with care and compassion, and with the understanding that we are the last person that will provide care. Okay? Other than that, postmortem care is pretty easy. We just wash the body and make sure it's clean in a clean gown with clean sheets so that the family can come in and say their final goodbyes. CNAs don't remove tubes. That's a nursing function. Good. Now you can be trained in certain circumstances, but if it is a medical examiner case, an ME case, those tubes must remain in place for the patient to be transported. So we don't just automatically remove tubes. Okay. So good? Makes sense? Those are the types of questions that we would have on the game show tomorrow, covering all of those topics. So tune in if you can. It's tomorrow at 11 a.m. on my YouTube channel. Today I have CPR. Anybody planning on attending today's CPR? 2. Okay. So we'll end class. You'll have a lunch, an hour for lunch, and then come back at 2 into this room and we'll get through CPR. All right. So if you have not taken the workplace personality quiz yet, you should. You should. This is going to give you a pretty good indication of where you are likely to thrive in healthcare. And unfortunately, a lot of people go into a healthcare setting knowing nothing about that setting. They just assume, oh, I want to work in a hospital. I think they watch too many Grey's Anatomy shows. I want to work at the hospital, not understanding that that may not be the right workplace for your personality and your needs. And they try to reshape the workplace to meet their needs, and that never works. So take the quiz. It's free. If you go on to, at the top of your syllabus, you've got flcnatraining.com. This is where all of the live streams are. The workplace personality quiz is on there at the bottom of the page for you. So it's an easy link. All right. So we're going to jump right into skills. No review today. I've reviewed with you enough. You guys should have these principles down by now. So we're going to jump right into bedpan. Now, bedpan has a lot of principles involved, but nothing really new. We're going to follow the care plan. We're going to do our opening. We'll use some gloves because we're working with body fluids. We need a barrier. We're going to scoot and roll the patient if we need to. Otherwise, we can ask them to lift their hips, which is way easier. We can do that for the test. We're going to clean the basin like we clean everything else and do our closing. I do have a video for this, but if you look at the bottom of the page, you're going to start to freak out a minute. So before you do, let me explain this. So this, for the test, should be able to be performed in 10 minutes or less. And it's going to be done on a live testing student. So let me explain how this works, okay? For the test, you are going to remain fully clothed. You are not really going to pee in a bedpan. We're going to give you a patient gown to put on over your clothing. And somebody will put a bedpan under your bottom and take that bedpan away, but you're not actually going to use it. And they're not going to clean you. Does that make sense? Okay. So this is important because it works into our care plan. What do we know about the care plan? We're going to follow it. So if we look at the care plan at the top of the next page, it says the resident has requested a bedpan. The resident is not wearing undergarments and can wipe self. So because this care plan says this, if anybody tries to take your clothes off, the evaluator can point to the care plan and say they don't need help with that. They're not wearing any. If the person doing the test, the candidate, starts to try to clean you in your personal area, the evaluator can say the resident is able to do that themselves. Again, everybody points back to the care plan for instructions. Good? So they will stop those two actions from occurring. But what does that tell the evaluator? If a candidate is trying to take their clothes off or clean them up, what does that tell the evaluator? You didn't read the care plan and you don't know the importance of following it. So should you be a CNA? No. So do you guys see that that's really what they're grading you on? Is your ability to read and follow that care plan? That's what it's all about. It's not about how clean you get the patient. It's about, did you follow the... It's a giant game of Simon Says. That's all the test is. It's a huge game of Simon Says. If you do something that's not on that care plan, you're out. If you don't follow the care plan, you're out. Good? That's the secret to passing the state exam. It's Simon Says. Okay? Like I said, you guys are ready. But let me explain to you a little bit about bedpan here. So this care plan says the resident is able to move as directed. Got a mouse here. There we go. It says that the resident is able to move as directed. So for the test, we can just ask our patient, can you lift your hips up? That's awesome. That makes this go so much simpler if we can just have somebody lift their hips up. But what if somebody can't? Well, if somebody is unable to lift their hips up to put the bedpan under it, we can roll them on their side, put the bedpan against their bottom, and then roll them back onto the bedpan. To get them off of it, you're going to hold that bedpan down and have them roll off of the bedpan and take it away. So if your patient can lift, that's what we're going to do here. If they can't lift, you're going to roll them to use the bedpan. Good? Now, rolling, much higher rate of spillage, by the way. Much higher rate. We'll get to that in a minute. But the first thing that I want to explain to you is that bedpan is never the first choice. Never the first choice. So toileting is always under a doctor's order, okay? So when a doctor writes admission orders for a patient to be admitted, either in a hospital or a nursing home or whatever, toileting is always addressed by the doctor under doctor's order. Is it bathroom privileges? Do they have a catheter? You know, what kind of toileting steps do we need? But the nurse is going to influence this as well based on the needs of the patient. Good? So they're going to work together here. So if the doctor writes an order, bathroom privileges, which means you get up and go to the bathroom just like you always get up and go to the bathroom. It's all, you. And the nurse thinks the patient is unsafe or unsteady, or a medication we're giving them impairs their gait or whatever, then the nurse will contact the doctor and they'll work out a different order. So it's always together. But I need you to understand that bedpan is never our first choice. Them going to the bathroom all by themselves is. That's way better. Okay, it's what they're used to. So if the patient can go by themselves, then they're going to go by themselves. And we call that bathroom privileges. Good? Questions? So the first question we ask is the patient even continent? Well, if they're not continent, if they're incontinent, we have a whole procedure for that. We just do pericare every 2 hours. But if they are continent, we're going to figure out, can they get to the bathroom on their own, or maybe even with a little bit of help. So bathroom privileges with assist. That's good. But what if they can't make it all the way to the bathroom? What if it's just too far? They're too weak. Well, then we have portable toilets, which you see there right next to my sink. A portable toilet called a bedside commode that we can bring right next to the bed, and the patient can just transfer from the bed to the portable toilet. It still gives a toilet-like experience. Okay? It feels very similar to being on a toilet. But if for whatever reason they can't use a bedside commode, now we're stuck with just 2 final options. Do they need a catheter? And we only use catheters when we absolutely have to. It's not a convenience thing. And if they aren't going to have a catheter, then we're stuck with bedpan. Do you guys see that bedpan is the last resort? Never the first option. Always the last one. We work on anything else but a catheter or but a bedpan. And the reason for that is because they're uncomfortable. They only hold so much. So chances are you're going to have to change the sheets. But the real reason that bedpan isn't used very often is psychological. Because you've been trained since you were about this big, don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. Just because we put a plastic pan under your butt doesn't mean your brain is going to let you go. You guys see that? So when we are using a bedpan, a lot of times we'll put a bedpan under a patient. They'll say they have to go and they're not going to be able to. So we'll try again in 10 or 15 minutes, or 20 minutes later, they'll hit the call light. And we're just going to keep trying until they can work it out and go. There are a few things that you can do to help them, though. You can turn the water on in the room. The sound of water does help with the urinary letdown reflex. You can spray warm water on the inside of their wrists or put their hand in a pan of warm water. That also helps with the urinary letdown reflex. Back when I was in school Mean Girls used to do that during sleepovers. First person to fall asleep, they would put their hand in warm water. Yeah, nice, right? Mean Girls. But it works. It helps. But there's a couple of other things that we have to think about, right? These rooms aren't private. There's a roommate. And whoever's using the bedpan may be afraid of sound or smell. So we can try to take care of that. The running water helps with sound. If the roommate can go for a walk, now's a great time to give our patients using a bedpan some privacy. We can use some air fresheners proactively before the event to help prevent smell. So there are a few things we can do to make this a little easier on our patients. But we need to understand that the psychological restriction is real. Good? Make sense? Okay. Don't be surprised if you put a bedpan under a patient and they can't go. But if they can go, that's problematic as well, because we have a bedpan, and let me show you a bedpan so you can see what I'm talking about here. This is a bedpan. If it looks like a toilet seat, it's where the butt goes. So this part goes underneath the patient. Imagine sitting on that, right? Toilet seats where the butt goes. But that's all the space you have between your undercarriage, which is going to sag, by the way, and the bottom of the bedpan. That's not much space. Now, urine is under pressure. We're pushing it out. When you have liquid under pressure hitting a flat plastic surface, you get splashback. That's right. So the whole undercarriage of the patient is going to be all wet. That is a clenching event. Okay. When you get splashback, you usually are very surprised and the urine stops. So that's not always a good strategy. All right. We can't really do much about this. You can't raise it up any further because now the person's trying to pee uphill and that doesn't work. So we have to understand this. There are some tricks that we can use to help, but we have to ask the nurse. If our patient is on intake and output, do you guys remember intake and output? Where we measure everything that goes in and everything that comes out. If your patient is on intake and output, we can't do anything about it. The urine has to be free in here so we can measure it. But if your patient is not on intake and output, then we can take big loops of toilet paper, big loops, just make like 5 or 6 big loops of toilet paper and lay it down inside. And that helps prevent the splashback. It also helps prevent sloshing because your patient getting on and off of this bedpan is going to press down on different parts of it, which means that we could have some sloshing. There's another reason that we're going to have sloshing as well. Bedpans are in the bottom drawer of the bedside cabinet. Remember, bottom is always the toileting area. So let me explain to you why spillage is a problem. Okay. So if we have a patient laying in bed and we take a bedpan and we put it underneath that patient, what did it do to their middle? Raised it up. How many of you ladies can pee uphill? You probably never thought about this, but when we put a bedpan under a patient, we made their middle higher than their head, which means that if they try to pee, they're having to pee uphill. Now, that's very hard to do, and if they are successful, that pee is going to run right up their back and into their hair, and that's pretty gross. So when we put a bedpan under our patient, the most important step is to put the head of the bed up. So your patient is in a normal elimination position. Good. And then the patient's sitting on the bedpan. You can't get it out from under them when they're sitting on it. So we need to put the head of the bed back down so they can lift their hips and we can take it out. So the most important steps of this particular skill have nothing to do with the bedpan at all. Has everything to do with the bed. Good. And if I don't point that out to you, you would never think about it. You'd put a bedpan under a patient and wonder why they can't go. We need gravity on our side. Good. Questions? So with all of this, lifting hips, putting hips down, head of bed up, head of bed down, whatever's in that bedpan is going to slosh all around. So we need something on the bed to protect the sheets when we're helping them with bedpan. So we're going to use the one thing that was supposed to be used for that, and that's a chucks or an underpad. So we're going to put the underpad under the patient, have them lift their hips, put the underpad under the patient. And you already know how to do this. Clean rolls toward me, dirty rolls away. So we're going to put the chucks underneath the patient, and then we'll position the bedpan on top of the chucks. Now, remember our care plan said the patient wasn't wearing undergarments. So there's a bare butt here. I know it looks like it has clothes on, and it will look like it has clothes on for the test, but it's supposed to be a bare butt. Do you want to touch a bare butt with bare hands? No, so you need gloves on for this. Good, right? It's personal skin. You need gloves on. Let's see here. Hold on, I got some comments. Ooh, boy, we got some comments. All right, hold on. Lauren, CPR classes today at 2. Yes, Lauren, at 2. And okay, Janae. All right, you're coming. Very good. We'll see you then. And do you need to be part of the class for the CNA? Vanessa, I'm not real sure what you're asking. Every state's a little. Oh, okay. Do you have to be in the class and pay prior to the 2 p.m. CPR class? No, Vanessa, anybody can come to the CPR class at 2. If you're a current student, currently enrolled, it's 45. Everybody else is 55. Just show up at 2. You don't have to be a student to participate. And we make it easy. All right. So when we put this bedpan under the patient, we're going to put a chucks and put the bedpan under the patient. And then we're going to make sure we have gloves on for that. But your gloves have just touched a bare butt. They have butt juice on them. They are now butt juice gloves. We know we have to put the head of the bed up. We just talked about that. We've got to be in a normal elimination position. Do you want to touch that bed controller with butt juice gloves? So we need to take our butt juice gloves off to put the head of the bed up. Good? Now, for the test, you have no other patients. There is nobody else to go see. This is it. This is your only patient. So you don't have to wash your hands and leave the room and go do, you should in a clinical setting. You shouldn't hang around because they don't need an audience. You should wash your hands and go. Go take care of somebody else. Go get some vital signs. Go do something and come back when the call light goes off. But for the test, we don't have anywhere else to go. You can't leave the room. So for the test, you're going to put the head of the bed up and just step around to the other side of the curtain and wait for them to say they're done. We're not doing that in a clinical setting, but we are for the test. So this is one skill where the test and a clinical setting is different. Clinical setting, take your gloves off, wash your hands, go see somebody else. For the test, take your gloves off. You don't need to wash your hands because you're not leaving the room. Just go wait. When they say they're done, you're going to put the head of the bed back down and then put some gloves on to take that bedpan and chucks out. Now we're going to take the bedpan and chucks together because first of all, it's a privacy issue. Nobody else needs to see what's in that bedpan. Privacy. But the second reason is infection control, because if your shoelace comes untied and you trip on your way to the bathroom, you are going face first into whatever's in that bedpan. So infection control and privacy. So wrapping the bedpan is an important step. Good? Questions on that? All right. So remember, you can't go lying flat. We have to put the head of the bed up, and we're not going to wear gloves when we touch that. Before you leave, you want to give them their call light so they can call you when they're done, and the toilet paper. Our care plan says they're able to wipe themselves, so we got to give them the tools that they need to get the job done. And then before we take that bedpan out, we'll put the head of the bed back down so that they're not sitting on it because you can't get it out. Cover the bedpan with the chucks for transport. And then we're going to dump it where do you normally go to the bathroom? That's where it gets dumped. Okay. We'll rinse it. Where do we want to put the rinse water? In the toilet as well. Okay. So we want to make sure that before we end this skill, we give the patient a hand wipe. Remember, they wipe themselves. Think about what's on their hands, and they're going to eat a tuna salad sandwich for lunch. So make sure that you give them a hand wipe, and then we can remove that blanket and pull up the sheet. But let me talk to you about this bedpan cleaner. You've got a picture of this in your book. I think it's on page 146. This is a toilet that you would see in an acute care clinical setting like a hospital or short-term rehab or something like that. And you've got something here that looks like a shower head. When you pivot that forward so it's over the toilet bowl, it'll start spraying like a shower. And it's called a bedpan cleaner. That's the whole purpose of this, is it's there to clean the bedpan right over the toilet. Works great. We love these things. It keeps you from having to use the sink. Much more hygienic. We like it. But there's a problem because this water is under pressure and it's going to hit a flat plastic surface, which means that we're going to have splashback. So if you're going to use a bedpan cleaner, we have to dress for the job. That means that we're going to protect our clothing because we don't want any of those fecal particles or urine particles splashing onto our clothing. So you want to put a yellow, I don't have one out here, a yellow isolation gown on over your clothing to protect it. You want to protect all the holes on your face. So a mask with a face shield would be appropriate. You don't want any of those fecal particles in your eyes. And of course, you need gloves. So all of those things would have to be put in place before you used a bedpan cleaner. Does that make sense? Otherwise, you're taking these particles on your face or on your clothing into other rooms. Good? Make sense? So bedpan cleaners can be used. They're great. They do a great job. Just make sure you dress for the job. Now, a note on odor. Masks do not help with odor. They don't filter out odor. So if you're odor sensitive, then you're going to have to do something other than a mask. I mean, you have to wear a mask to protect your holes, but it's not going to help with odor. If you get, Vicks, the stuff that mom rubbed on your chest when you were a kid and had a chest cold, right? If you put just a little bit of Vicks underneath your nose, it helps cut odor. So that's a really good trick. Now, I can't use Vicks because I have super sensitive skin and I will look like Rudolph in like 3 seconds. I just turn all red and blotchy. It's not good for me. So I make my own. Go get a little thing of Vaseline from the Dollar Tree or wherever. Put a couple of drops of your favorite essential oil in it, mix it up, and then you can make your own if you don't like the Vicks smell. But it's got to be somewhat strong to help overcome the offensive odors. Now, there's some odors that, no matter what you do, you're not going to be able to cut it effectively. But it can help for those of you that are particularly odor sensitive. Okay, good. Just remember the mask won't help with odor. All right. So when we're putting a bedpan under the patient, make sure that the part that looks like a toilet seat is under the butt. Now, you're putting the head of the bed up. We talked about that. That means that where the bed bends is where the patient bends. That's exactly where we're putting the bedpan. So when we get that bedpan in place and we put the head of the bed up, that bedpan is probably going to shift either up or back because it's right where the bed is bending. So we can tell the patient you can adjust that if you need to. Just make sure it feels like it's under you. Or you may have to, after you get the head of the bed up, adjust it a little if your patient can't do it. Okay, but remember, when you put that bedpan in place, it's right on the bend. So it's going to shift one way or the other because the bedpans don't bend. Okay. Now we use bedpans for urine on females and bowel movements on both sexes. For males urinating, we use something called a urinal, which looks like a milk jug, basically. And they don't usually use bedpans for urination. They use something a little different. All right, so our important steps here is we're going to ask our patient to lift their hips or roll on their side. We'll put a chucks under their hips, position the bedpan under the patient, and we're going to ask them if it's comfortable. We'll raise the head of the bed, give them their toilet paper and call light. When they're done, we'll lower the head of the bed, put our gloves on, remove the bedpan and chucks, cover the bedpan with chucks for transport, clean and store the bedpan, remove the gloves, and then give the patient a hand wipe and do our closing. Okay. So we have 10 minutes to get all this done. It does not take 10 minutes to do this skill. It does not take 10 minutes. Good. Lots of time here. All right, so I'm going to show you the video for this one.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I understand you need a bedpan. Can I assist you with that?
Sure.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll need a chucks and a privacy blanket for this skill. Okay, Mr. Jones, I'm going to place this privacy blanket over you. This will help keep you warm and protect your privacy as we do this skill. Is that okay?
Yes.
Okay. I'm going to spread this out without snapping it or shaking it. And I'll have you hold this in place so I can pull your sheet down. That way your sheet remains clean as we do this skill. Okay, I'm going to prepare a chucks to place under you before we put the bedpan in place. I'm going to hold the chucks up lengthwise and roll it toward me. Clean rolls toward me, dirty rolls away. And I'll just place this on the bed. I'm going to open the drawer that the bedpan is in and get a set of gloves. Okay, Mr. Jones, in just a moment, I'm going to ask you to bend your knees, lift your hips as high off the bed as you can, and I'm going to unroll the chucks underneath you. Okay?
Okay.
All right, go ahead and bend your knees and lift up. Okay, and you can relax. I'm going to go around to the other side of the bed and unroll it. Okay, Mr. Jones, can you lift up again, please? I'll smooth the chucks out, making sure it's positioned properly on the bed. You can relax. Okay, now I'll get the bedpan out from in the drawer. And I'm going to place this under your bottom, if I can get you to lift and relax. Is that comfortable?
Yes.
Okay, I'm going to put the head of the bed up, but let me remove my gloves first.
Okay.
Okay, I'm going to put the head of the bed up. Please tell me when you're comfortable.
Okay.
And you may have to adjust that bedpan a little bit as it moves. Tell me when you're comfortable.
That's good.
Okay. Here's your toilet paper and your call light. And I'm just going to wait out here. Please let me know when you're done. Okay, Mr. Jones, I understand you're finished. Let me help you with that. I'm going to put the head of the bed down now. And please do not lift your hips. Once the head of the bed is in the lowered position, I'll put on a pair of gloves. And I'm going to hold that bedpan flat as you lift off of it. Okay, Mr. Jones, I'm going to take a corner of the chucks and hold the bedpan flat as you lift off of it. You can go ahead and lift on the count of 3. 1, 2, 3. Thank you. I'll remove both the bedpan and the chucks and take them to the bathroom for disposal. I'll be right back. Once I get over here to the bathroom, I'm going to unwrap the bedpan and we'll throw the chucks away. I'm going to empty the contents of the bedpan into the toilet, and then I'll rinse the bedpan. We'll deposit the rinsed water into the toilet as well. And then we'll set the bedpan down to dry. I'll pick it up with a paper towel. I'm going to dry the inside. We'll throw that paper towel away. I'll dry the outside, throw that paper towel away, and get one for the drawer. Okay, I'm going to place the bedpan in the drawer along with the toilet paper. And we'll use the paper towel to close the drawer. Now I can remove my gloves. Mr. Jones, would you like to wipe your hands? Thank you. Okay, you can relax your legs if you'd like. And I'm going to pull your sheet up and remove the privacy blanket. We want to make sure that we roll the blanket in a ball so that any trailing edges don't contaminate other surfaces. There you go. Here's your call light. I'm going to go put this in dirty linen. I'll be right back. Okay, Mr. Jones, are you comfortable? Is there anything else I can get for you while I'm here? A magazine, perhaps? Your call light is there. Please let me know if there's anything that we can do. I'm going to open your curtain and go wash my hands.
Thank you.
After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. Okay, any questions on bedpan? Any questions on bedpan? No? All right. So one of the questions I get asked quite a bit is, do I have to say everything you say? I mean, do I have to use all those words? And the answer is yes and no. So let me explain the difference there. So during the exam, you're going to be nervous. And it's very awkward for patients to have somebody working on them that is completely silent. It's awkward for them. So talking to the patient is actually a pretty important part of what we do. And telling them, if we don't have anything else to talk to them about, telling them the steps that we're taking is a great way to at least engage in conversation. For the test, it will also help you remember your next steps, talking it out. But remember, it's all about the patient. So we really should be thinking about this from the patient's point of view. If I'm going to get into their drawer, they don't know why I'm going in that drawer. It could be to steal money out of their wallet, or it could just be for a toothbrush. How do they know the difference? So remember that this is their room and their possessions. And just like in your home, if somebody went into your dresser, you'd want to know why. Right? So we have to not lose sight of the fact that this is their stuff. and they have a right to know what we're doing with it. Just like in a hotel, you don't live in a hotel. You're not there for very long. You're there for a night or two, maybe a little longer, but still, you're renting that space. If somebody were to go through the drawers, you would consider that a violation. So we tend to forget all this when we get into a clinical setting. We think, oh, well, they're in my facility. No, you're in their room. So we have to have a little bit different mindset. So yeah, everything that I say to the patient, you probably should say, just so that they're kind of kept up to date with what's happening. You should also say it to help remind you of the next step. But you should, for the test, also say it, because when you're doing these skills, that evaluator is looking at the checklist. If they're looking down here, checking things off, they may not see you do a step. But if you're saying the steps out loud, they'll hear it. Does that make sense? Now, please bear in mind that everything I say in these videos or in the live demonstrations is to teach you how to do the skill. So I'm probably giving more information than you need to. But out in the clinical setting, I do it the exact same way. If you were to see me in a clinical setting performing these skills, I use the same words. I don't vary from it. Same words. Because in here, I'm trying to teach you. But out there, do you know who else doesn't know what I'm doing or how to do the skill? The patient. Absolutely. And one of the biggest issues that we see in healthcare is CNAs expecting the patient to know what's next. How would they? You didn't know what was next. You had to take a class to learn what the next step is. So don't expect them to know it. They didn't take the class. Does that make sense? So there's a lot of really good reasons, but there's no checkpoint that says used all the words Miss Patty used. Okay. No checkpoint that says that. But talk it out as much as you can. All right. So we're going to move on now to catheter care. This is on page 158. This is a long skill. Not as long as two others, but it is still a long skill. Remember that partial bed bath, they gave us 19 minutes. Peri-care, they gave us 17 minutes. This one, they're going to give us 15 minutes to do. It's just like peri-care with an extra step, but they're going to give us less time to do it. So let me explain why. If you look down the sidebar here, you can see that every single principle is at play here except for shoe rules. That's the only principle that does not apply to this skill, just like peri-care. All those principles are going to apply. They're all written out for you here. You guys should know these by heart by now, but they're written out here for you as a review. I do have a video for this. Short form is here. And along the bottom, you can see our skill-specific information. Somebody with your level of experience should be able to do this in 15 minutes. It's going to be done on a mannequin. The mannequin will be laying in bed. Page 159 has our care plan at the top of the page. It tells us to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So remember with peri-care, we had to clean their backside. Our care plan does not tell us to clean their backside for this skill. And that's because the tube is containing all the urine. The patient isn't laying in urine. So we don't have to clean the backside. Good? That's what makes this a little bit shorter. Because with peri-care, we had to turn the patient over, wash, rinse, and dry the backside, and then change that pad again. So that took a little bit more time. This one, we're going to clean the front of the peri area and the tubing. But while we're doing that, we'll put a chucks under them and then take it away at the end. Okay. So all of your steps are detailed here. You can see your supplies at the bottom of the screen here. And this is very, very similar to peri care. So with peri care, we change the chucks out. We clean top to bottom using 5 strokes. Whatever we washed, we rinsed. Whatever rinsed, we dried. We clean the back side, cheek, or up the middle, cheek, cheek, up the middle again. Whatever we wash, we rinse. Whatever rinse, we dry. And then we change the chucks again. So that was peri care. For catheter care, it's pretty similar, but they're not going to start out with a chucks. We're just going to put one there while we're cleaning to keep the sheets dry. Here's the thing about chucks or under pads. We don't want one under the patient if we don't need one under the patient. First of all, they tend to bunch up as people turn over and move in bed. That creates wrinkles. What do we know about wrinkles? Yeah, they contribute to bed sores. So that's not a good thing. They also, because they're plastic lined, they hold in body heat. So we end up with warm, dark, moist. So patients sweat, when they're on these pads. So it's not ideal. Sheets are cotton. They tend to wick away moisture. So it's not ideal to have one of these pads under the patient if we don't need one to capture fluid that we know is coming out. Okay. So the patient won't be on a pad to start, but while we're cleaning, we have to protect the sheets. So we're going to put one there while we're cleaning, and then we'll clean the front, we'll clean the tubing, and then we'll take that pad away. Okay, good. So we're not going to clean the backside, and we're not going to leave the patient on a chucks at the end of the skill. Let's talk about catheters though. So catheters are usually cleaned once a shift. We're going to clean the catheter and the skin around it. That's what catheter care is, the tubing and the skin around the tubing. But while we're there, we also need to inspect the tubing and the bag. The bag should be on a non-moving part of the bed, and it should always be lower than the patient's hips, and the tubing should not be kinked. Shouldn't be kinked. So catheters are always attached to bags. This whole unit creates what we call a closed system. So by closed system, what I mean is this end is inside the patient, okay, from like here up, inside the patient. So no bacteria can get in, it's inside the patient. The rest of this is all closed. There's no opportunity for bacteria to get in unless we do something to open the system. And that's what we're going to talk about now. So let me explain to you the different parts of the catheter. So way up here at the very top of the catheter, this is inside the body. The tip of the catheter has a hole in it. It kind of looks like this. Tip of the catheter has a hole. That allows the urine that's in the bladder to enter the catheter and go down the inside of this tubing. Think of this as a flexible straw. It's really all it is. Flexible straw. It's going to be held in place by, it's hard to see on this background, but it's going to be held in place by a balloon that we fill with water. So once we get the catheter in place, I'm going to show you this in a minute, but once we get the catheter in place, we're going to fill that balloon with water, and it's going to hold that catheter inside the bladder. To take the catheter out, we take the water out of the balloon, and then it just slides right out. Okay, good. This is the catheter tubing itself. And then down here at the end, we have 2 ports. This one is going to attach to a collection device, and this one is where we put the water in for the balloon and take the water from the balloon out. So this port is going to connect to some sort of a bag. If this was just open, man, the pee would go everywhere. So how often do the kidneys create urine? All the time, 24 hours a day. So if this isn't connected to anything, where's all that urine going to go? Everywhere. Everywhere. So we have to have a device to collect all that urine. It's just a bag. That's all this is. It's just a bag. Now there's big bags and there's little bags, depending on what kind of bags we need. Just like Ziploc bags, right? You've got little snack size Ziploc bags. You got some sandwich size Ziploc bags. You got some gallons size, right? All kinds of different sizes. Same thing with these bags. What kind of a bag do we need? So this is where it connects. This is called a port, where it connects. And then you have tubing. And the tubing's pretty long. That tubing is going to terminate at the top of the bag. And the bag is going to have measurements on it. We don't use these. This is for eyeball purposes only. This is not an accurate measurement. We don't use this to measure. We have an emptying port here. This is how we're going to empty the urine out of the bag. And that port has a little house that it lives in. Those are the parts of the bag. So the catheter and the bag are two separate pieces. That's important. Catheter and the bag are two separate pieces. Whoa. Okay. Catheters are generally changed out once a month. So when we put a catheter in, when I put a catheter in and I inflate the balloon to keep it there, this can stay in for up to 30 days before it has to be changed. But the bags themselves are usually changed once a week. Because this is changed more often, we have to have a way of separating them. Okay. So the port of the bag plugs into the opening on the catheter. That's it. That's it. Now, CNAs don't change bags unless you've been trained to do so. Because, remember I said it's a closed system, nowhere for bacteria to get in, unless we allow it in, unless we open the system. That's what we're doing here. When we take the bag out, we've opened the system. That allows bacteria to get in, especially if there's bacteria on this port. And to put the port into the hole, you really kind of have to push it in there. And it's very easy to introduce bacteria. So you have to be trained to do this. This should be a very clean procedure. Good? Questions? So catheters have a hole at the top. The urine falls down through the catheter. And this port down here that has a colored little end on it, this port is, we put a syringe. It's how we put water in and take water out. Get a little more water here. Now, when nurses put catheters in, CNAs don't put catheters in. That's not your job. When nurses put catheters in, they will use sterile water. And here, I'm just using tap water to show you. But here, okay. So if I were a nurse putting this in, I would insert the catheter. We're going to lubricate it. I'm going to insert the catheter once it's in place, and I know it's in place because I get urine. Urine starts to come out. Then I'm going to inject the water, and that blows that little balloon up. And now the balloon acts as a doorstop right on top of that valve at the base of your bladder. You guys remember that valve? Okay. So catheters are usually changed out every 30 days. The drainage bag is going to be changed a little more often, about once a week, and CNAs can be trained to make that change, but not initially. So for the test, you do not change the bag without additional training. So CNAs, what are CNAs responsible for? We're going to clean the catheter and the skin around the catheter. We're going to empty the drainage bag and document the output. We're also going to make sure that the bag is lower than the hips and the tubing is not coiled near the floor. So you can be trained on changing that bag. So remember this, the chain of infection. This is a problem when it comes to catheters. Urinary tract infections from catheters are a leading cause of death. Let me explain why. We even have a whole name for it. It's called a CAUTI, C-A-U-T-I, catheter-acquired urinary tract infection. Do you guys remember when we were talking about this initially, I told you 1 out of every 25 people in the hospital got something that they didn't come in with? You guys remember that? This is the most common thing they get. A C-A-U-T-I or a CAUTI. So if you remember the urinary system, we have kidneys that filter blood 24 hours a day, that produces urine. Urine drip, drip, drips down these tubes, accumulates in the bladder. You get a little valve here at the bottom of the bladder that holds the urine in there until you go to the bathroom. We remember that. Now, when we have a catheter, that system still works. We haven't changed anything. We have just taken a catheter, we've inserted it into the bladder, blown up that balloon, and now that balloon sits right on top of that valve. So now the urine is going to go into the tubing through that little hole and down through the tubing into our bag instead of out of the body naturally. Good? You guys understand how this works? All we're doing, all this does is hold that valve open and provide a tunnel for the urine to go out. That's it. That's all a catheter does. That's it. But it's a little bit dangerous. And that's because urine flows freely out of the bladder and collects in the bag. It's a closed system. That means that whatever is in this tubing or this bag does not have any contact with our white blood cells. So if bacteria, remember we talked with Pericare that when we're doing Pericare, we don't want to bring busloads of bacteria up because we have some white blood cells that are hanging out in this tube, this urethra, that if a bacteria or two stumble in, the white blood cells get rid of them. But if we bring too many at one time, the white blood cells can't overcome it. You guys remember that? Well, this is even worse. And that's because if we let bacteria in here, that bacteria is inside the tube. The white blood cells are outside the tube. There's no way to protect the patient. Do you guys see how dangerous this could be? Gets worse. Gets worse. We're going to talk about that in a minute. So we got lots of different types of bags for different purposes. These are the two main bags you're going to see. This is called a bedside bag. It's what we have here. It's a large bag. It holds a lot of urine. And we usually empty it once a shift. You can see it's going to hold quite a bit of urine. And we're going to empty it once a shift. But if your patient is out and about in the community, just because you have a catheter doesn't mean you're confined to bed. These people can be out roaming. They can be at Winn-Dixie, Walmart, Busch Gardens, I mean, all kinds of places. So if we have somebody with a catheter that's in the community, they don't want to carry a suitcase of urine everywhere they go. That's embarrassing. People stare. It's weird, right? So we want something a little more discreet. And that's what this is. This is a leg bag for ambulatory patients. It's going to use elastic straps to connect to the inside of the thigh or the inside of the calf, depending on your patient. And it just those elastic straps just hold that bag in place. The urine comes out of the tubing and into the bag. Patient just goes to the bathroom, opens the valve on the bottom of the bag, the urine goes out into the toilet, they close it, and off they go again. Most patients that have leg bags will manage those on their own. We're not involved. You'd be surprised at how many people in our community are wandering around with catheters. And you'll never know because it's discreet. Okay, good. All right. So if we let pathogens enter this system, there's nothing to stop them. And remember, we don't need boy bacteria and girl bacteria to have baby bacteria. We just need the right ingredients: warm, dark, moist, and certain enzymes and proteins which are present in urine. So if we, when we're emptying the bag, let bacteria get in here, this bag is clear by design. We're trying to allow light to penetrate. Because remember, bacteria need warm, dark, and moist. We've got warm and we got moist. So light will help prevent them from proliferating too quickly. They're still going to multiply, but we're just slowing them down a little bit. Because as they multiply, they climb. Now, when they get up here, they're getting fresher urine, warmer. They're going to keep multiplying, keep multiplying, keep multiplying, keep traveling. By the time they get up here, we've blocked out light. Really warm urine. Remember, urine's about 100, 101 degrees, right? So by the time these bacteria get up here, they are ramping up. So we start out with one bacteria and that becomes 2, and then 4, and then 8, 16, 32, 64, 128, 256, 512, 1064, and so on. And it just amplifies minute by minute. Because you're not just having one bacteria that's dividing, you're having thousands. So it doesn't take long for this infection to get overwhelming very, very quickly. So by the time those bacteria jump out into the bladder, there are trillions of them. This is an overwhelming infection that seems to happen out of nowhere. Your patient was fine. 20 minutes later, they're running fever. They feel like crap because these bacteria have proliferated and invaded in such big numbers. It's very difficult to get this kind of infection under control, which is why it's a leading cause of death. Remember, these aren't healthy patients. These are people that are already fighting off something else. Does that make sense? That's scary. So when we are emptying the bag and doing catheter care, our goal is not to allow any pathogen intrusion. Okay. So there's only 3 points that bacteria can enter the system. One is inside the patient. That's the nurse's problem. Okay. Her goal is not to bring any bacteria with her when she puts a catheter in. The second point is here when we change the bag out. The third point is the one we're most concerned about, and that's the emptying port on the bag. Now, it's the furthest from the patient, so it takes a long time for this bacteria to make the climb to get up into the patient. Long time, which is why we change the bags out more frequently. Good? Makes sense? Long time. But it also means that we've got to be super careful not to let any bacteria in when we're emptying that bag. So drainage bags should be affixed to a non-moving part of the bed above the floor. You never want a drainage bag to touch the floor. Remember, pathogens live on the floor. So you want it above the level of the floor, but never above their hips, because if you raise that above the hips, that urine's going to run right back into the patient. And I don't know about you, but recycled urine's pretty high on my gross meter, right? Urine should be a one-way trip. I don't want it to come back. So we've got to be careful not to raise the bag up. Now, I watch a lot of medical shows on TV, and it amazes me. Like My 600-Pound Life, I love that show. And it amazes me how many caregivers, CNAs, PCTs, whatever you want to call them, are walking these people down the hallway after surgery, holding the urine bag up like this. Like, no, don't do that. That's no good. So don't raise the bag above the level of the hips. Sometimes catheters come out. It happens. So if a catheter is pulled out, sometimes patients do it because it doesn't feel right. It's uncomfortable. Should never be painful for a patient. If the patient says it hurts, go let the nurse know. Because there are some people that when we put a catheter in, their body sees it as a foreign object and the bladder spasms to try to push it out. Have you ever had a Charlie horse in your leg? Anybody ever have a Charlie horse? It hurts. I mean, it really, really, really hurts. Well, this is a Charlie horse of the bladder. When your patient says it hurts, believe them. Go find the nurse. Go let them know. We have a medication we can give to put that bladder to sleep. So the patient won't feel that pain anymore, which is good. But every medication has a risk to it. We can't just automatically give people these medications because in a very small percentage of people that take this medication, the bladder never wakes up. So that means that we have to have a catheter for the rest of our lives. So again, this is all about working as part of a team, right? We're not making these decisions on our own. That actually happened not too terribly long ago. A CNA was caring for a patient. The patient was saying that it hurts. And the CNA took the catheter out. Just took the catheter out. And she was asked, who gave you the authority to do that? And she says, well, the patient was hurting. Yeah, what should she have done? Yeah, we don't make decisions, right? How happy do you think that patient was to have another catheter put back in? It's bad enough once. Let's not do it again, right? Good? Makes sense? Be careful not to overstep your bounds. But sometimes because they are uncomfortable, they should never be painful, but they are kind of uncomfortable. And the reason for that, let me go back here. Where is it? There we go. The reason for that, if you look at this, you see the balloon here, and that's holding that valve open, right? The tubing is holding the valve open. The balloon is sitting at the base of the bladder. But do you see how this tubing doesn't take up all of that space of the urethra? Because that tubing doesn't take up all of that space and the valve is being held open, urine is going to leak. So when we have a catheter in place, we've got to make sure that the catheter size we pick, and yes, they come in different sizes, the size we pick is going to take up all of that space. So it's snug, not painful, but it's snug. So it's kind of like, I don't have anybody in here that has gauges. So a couple of years ago, gauging your ears was really popular, where you just stretch out that ear hole. And every time, you get it just, so it finally fits, then you have to size up to get them bigger, right? So that's what this is. It's got to be snug. So it's uncomfortable. Definitely not what I would say a walk in the park, but not painful. Does that make sense? Everybody with me? So because this is snug in that space, if you've got leakage, if we've got a catheter and we have leakage, we need to let the nurse know. And they'll probably change it out for a slightly larger catheter. Remember, there's different sizes. But because it's uncomfortable, sometimes your patient will pull it out. And if the patient pulls it out, there's a couple things that you need to do. First of all, don't just go throw it away. Because when a catheter gets pulled out, as the nurse, I've got to look at that catheter. I have to inspect it and see if it's all intact. So if a catheter gets pulled out and the balloon is like this, that's okay. I can work with that. I can deal with that. Now, that's going to hurt the patient. Think about that. You've got a balloon this big going through a space this big. we're going to get tissue tearing. There's going to be a little blood. There's going to be a little urine. Your patient is fine, but man, that is going to sting like crazy when they pee through it. Right? So the problem is that when you have an injury, there's always swelling. That's probably not a place we want swelling, right? So if a patient pulls a catheter out, you need to let the nurse know right away, because they only have about 45 minutes to put another catheter in if we need to. Otherwise, the swelling is so bad that we're not going to get a catheter in for a while, and the patient's going to have to pee through that torn tissue. So this is not a go take your break and see other patients and tell them at the end of the shift. We need to tell them now. Good? Make sense? All right. But sometimes when a catheter gets pulled out, the balloon bursts. And when the balloon bursts, it looks more like this. I'm going to pass these around so you can see. Now, if you have a catheter laying in the bed and there's no balloon, you need to let the nurse know like right now, because chances are a piece of this balloon is still inside the patient. That's not something that we can ignore, because the body will see it as a foreign object and attack it. So this becomes a doctor problem. Good? Make sense? So if the catheter comes out and the balloon is intact, the nurse can deal with that. If the balloon is not intact, it's a doctor problem. How would a nurse know which problem we have if you threw the whole thing away? So if a catheter comes out, leave it attached to the bag. If it was attached, if it wasn't attached, however you find it, put it in an empty trash bag in the bathroom. And then go find the nurse and say the catheter was pulled out. It's in an empty trash bag in the bathroom, and they'll take it from there. Okay. So I'm going to pass all this around to you. So I'm going to pass a couple of different catheters that all have burst. And you can see on some of them that some of the pieces are missing. Now, these are real catheters that were in my mannequin that burst. So you can see they degrade over time. So you can see what it would look like. They haven't been used on real people, just the mannequin. Okay, but as bad as that is, and that is pretty bad. Yeah, I'll show you close up in just a second. I'll get to your questions in a second. So as bad as that is, unfortunately, CNAs pull out way more catheters than patients do. Way more. It is very rare for your patient to pull a catheter out. It's very common for you to do it. So let me explain to you how that happens. If the tubing is coiled near the floor, your foot could get stuck in it as you're walking and pull it out. This happens a lot. So we want to make sure that the tubing is coiled on the bed, not near the floor. That's bad enough. But this is probably worse. Remember that one of our jobs is to ambulate patients. Another one is to transfer them out of bed and into a wheelchair. If you don't look to see if they have a catheter before you do these tasks, that catheter will stay on the bed or the chair and it's not going to go with you. As the patient is walking, that pressure will actually pull the catheter out. Remember, the only thing that's holding it in is a balloon filled with water, right? It's not a huge, amount of resistance there. So when we are working with patients, we really need to look for a catheter, especially for mobility skills. Another way that this happens is when we turn a patient over in bed. If they have a catheter and we're not paying attention, our leg can trap that catheter against the mattress. And as we turn the patient, the catheter comes out. There's lots of ways that we unwittingly contribute to this. So it's way more common for CNAs to pull catheters out than it is for patients. The problem here is integrity. If you pull a catheter out, you can't hide it. And a lot of CNAs do. They'll just leave the catheter in the bed for the next shift to find. Who does that hurt? The patient. Absolutely. But the CNA doesn't want to get in trouble, so they just don't report it. Remember, this is an integrity issue. Okay. Some CNAs that get terminated for that, they go, well, I just made one mistake. But it's not really one mistake if it's an integrity issue, is it? If you make a mistake, you have to own up to it. Don't ignore it. Don't sweep it under the rug. Don't pretend it didn't happen. Own up to it. Okay, so if you want to turn around, you can get the... So if a catheter does get pulled out, the CNA should place the catheter in the drainage bag in a clean, empty trash bag or wash basin in the patient's bathroom for inspection by the nurse. Don't just throw it away. You need to notify the nurse right away. So let me show them close-ups of this real quick. So this one is a catheter with an intact bubble or balloon. This is the end right here that we inject or remove the fluid for this bubble. And this is the port that the bag plugs into. This is a catheter. Let's see if I can get it. There we go. This is a catheter that has, the bubble has burst, and you can see it's actually missing a piece out of it. It's missing a piece. So this would be a problem. This is an example of one that isn't missing a piece. No piece missing. Okay. So there's a couple different types of catheters. The one that we are most familiar with are these. These are called indwelling catheters, which means they're put in, a balloon is inflated to keep them in for up to 30 days. But sometimes we don't need a catheter that stays in. Sometimes we just need to empty the bladder and be done. In that case, we're going to use a different type of catheter. This is called a straight cath or intermittent cath. It's also called a Red Robinson. So catheters don't just have two names. Most of them have three. So this is called an indwelling catheter or a Foley catheter. Or some people will call it a regular catheter. So usually when we're talking about catheters, these are the ones that we're thinking of. This is called a straight catheter or an intermittent, which means we just put it in, drain the bladder, and take it out. Notice this only has one opening. Remember, this one had two openings, one for the bubble and one for the bag. This one just has one opening for the bag. Or sometimes we'll just empty it into a basin, depending. No bubble here. The rest of it is the same. This is for intermittent use. Just put it in, empty the bladder, take it out. Okay, good. Now, I was the ESE RN for the county school system many years ago, and we had children with spina bifida in the elementary level that were able to self-catheterize themselves because they had no control over their the valve. They couldn't open it because of the spina bifida. So they were taught at a very, very, very young age how to insert catheters to relieve their bladder. And you would have 6, 7, 8-year-olds doing this all on their own. So this isn't a hard skill. If we can teach a 6, 7, or 8-year-old to do it, it's not a hard skill to do. Okay, good. Makes sense? Good. Now, we do have another type of catheter, and that's called a Texas catheter or a condom catheter. This is also called an external catheter. Remember, catheters all have 3 names. This is used on males, and like the name suggests, it's applied like a condom, has a port, so that port is where the bag would attach, but this is external. Nothing goes inside the body. It just stays on the outside and directs the urine away. Now, the problem with these, they have to be changed every 3 days. They're sticky on the inside, so they hold. But the problem is that this has what we call a reservoir tip. So some urine is just going to sit there right against the tip of the penis. And remember, this is adult urine, so it's very acidic. So if we're going to use one of these, we want to make sure that when we're removing it and cleaning, we're really cleaning really well to get all of that acid off. And then we'll probably, on the care plan, it'll probably have you put a skin protectant, which is kind of like a layer of extra skin. It's a wipe. It kind of looks like an alcohol wipe, but you put it on the skin and it actually forms an extra layer to help prevent something called maceration or the eating of skin. Okay, so if you're going to use an external, make sure you're cleaning very well and applying the skin protectant if the care plan tells us to. Good? Questions? All right. So let's go back up here real quick. And Vanessa says, do we need to record the fluid on the chart? Now, that's going to be the next skill that we learn. Okay, emptying the drainage bag. And yes, we will have to record that. And contamination, it's terrible. My prior job was cleaning janitorial. That's why I changed careers. Yeah, absolutely. We want to try to... Okay, this is a good question. They usually do this when a mother is in labor, right? Let's talk about that. So with catheters, we are going to use a catheter when it's indicated. If the urine can come out on its own, it's better to come out on its own without a catheter, because remember, catheters are risky. There's a high level of contamination or infection with them. So if we can get away with not using a catheter, that's good. We're going to try to do that. But if we can't, then a catheter is indicated. Now, we often use catheters when you're in surgery. You don't know it because we wait until you're out and we put one in, okay? But we don't, because we're putting the whole body to sleep. We're also putting that valve to sleep as well, which means that whatever urine the kidneys produce is going to come right out, right onto our sterile field. And we don't want you doing that during surgery. So during surgery, we usually put a catheter in and then we take it out in recovery. You probably didn't even know, if you've ever had a surgery, that you had one in. Probably not even aware. But we use them a lot for surgery. We also use them when a woman is giving birth, particularly if we gave her an epidural or a C-section, but particularly with an epidural. And that's because we literally are putting everything from here down to sleep. And when you push, whatever's in there is coming out. It's not selective. You're not just pushing baby. You're pushing urine and feces and anything else that might be in the way out. So we don't want, a lot of young women that haven't given birth don't understand. It's not selective pushing. So we don't want you peeing on baby. So because you don't, especially with epidurals, because we've numbed everything, you can't walk. You can't get up and walk. So it makes toileting issues harder to manage. So a lot of times we'll use a catheter when we have an epidural just to take that consideration off of the table. We got a lot of other things going on. So just to take that off the table. Sometimes with C-sections, because it is a surgery, a catheter will be put in place. And then it's usually removed pretty soon after the C-section, because we want to make sure everything is working well before we send you home with a brand new baby. You know, we want to make sure that you're at least in good, good shape. Good? So you guys understand the different types of catheters? Okay. So how do we clean a catheter? Well, we clean a catheter like we clean peri-care, right? We're going to clean the tubing and the skin around the tubing. So in order to clean the skin, we're just going to hold that catheter up out of the way. and we're going to do peri-care. So we'll use that same leaves method. So I have my washcloth held in my hand, 2 corners tucked in, free edges at the top. I'm going to hold the catheter out of the way and go once down the middle. I'll fold that over. I'm going to clean one side, fold that over, clean the other side, fold that over, skin fold it over, and skin fold. Whatever I wash, I rinse. Whatever I rinse, I dry. So it's peri-care. We're just going to hold that tubing up out of the way. Easy peasy, right? All right. Remember that we always go down away from the urethra. That doesn't change. Now, when we're cleaning the catheter tubing itself, remember it's just a balloon that's holding that tubing inside the body. If I take my washcloth and I try to pull and I'm not holding that tubing, it's going to pull the tubing right out. Good? So when we're cleaning the tubing, we want to hold it where it exits the body and then clean, moving away from the body. We'll fold that leaf over, wrap, clean, fold that leaf over, wrap, clean, fold that leaf over, wrap, clean. Okay? Whatever we wash, we exact same way. Whatever rinse, we dry. Not much to learn here. So our care plan says to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So one of the ways that people do this wrong on the test is they clean with alcohol. What does our care plan tell us to do? Soap and water. Imagine alcohol in that area. So this is a common testing issue that we don't want to repeat. We don't want to repeat that. Don't use alcohol. First of all, it goes completely against our care plan. Completely. But the other issue is that you can't use the leaves method. So you're not changing the area each time. So you're cross-contaminating everything. Does that make sense? Don't use alcohol. All right, so to do this skill, we're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do catheter care. Is that okay? They say yes. You close curtain, wash hands, and start to get your supplies. But before we get our supplies, we'll get a barrier to put them on. After we get our barrier, we'll get the rest of our supplies. We're going to get some water. Using a paper towel to turn the faucet on. It should feel warm. We're going to check it. Who else checks it? Patient. That's right. Once we get everything in place, we'll put the privacy blanket on and pull the sheet down underneath. And then we're going to put our gloves on because the first thing our gloves should touch is the patient. Oop, nope, we are not on break. Not yet. Then we're going to turn our patient over to the side, scooting them toward us first. So they're in the middle of the bed after the turn. Put the barrier on or the chucks on the bed. Put them back on their side or on their back in the middle of the bed and smooth out the chucks. That way the sheet is protected. We're going to roll the blanket up, exposing the patient just like we did with peri-care, covering the legs with a towel, making sure that the catheter tubing is over the towel. And then we'll wring out our washcloth, apply soap to all 5 corners. Remember, we use the leaves method when we're washing any wet body opening. So once we have soap on all 5 leaves, we're going to hold that catheter and we're going to wash down the middle, side, side, skin fold, using the different leaf for each stroke. And whatever we wash, we rinse. Then we'll dry top to bottom. After that, we'll wring out another washcloth and soap 4 corners. And then hold that catheter and clean down the catheter 4 times using a different leaf for each stroke. Whatever we wash, we rinse. Whatever we rinse, we dry. Now we can take that or cover the patient up, take the chucks back out from under the patient because we don't need to leave it there. After we have done that, we want to leave the patient covered with a blanket because we need our gloves on to take care of all of that stuff. Think about where the stuff has been. And we can't touch that sheet with those gloves. So leave the patient where they are. Take care of all of your supplies. Put them in dirty linen. Clean your basin. Put it away. Then you can remove your gloves. Take the blanket off. And pull the sheet up and then do our closing. Our closing is, thank you very much, Ms. Jones. Is there anything else I can help you with? Are you comfortable? Would you like anything before I go? Environment's clean, bed's in the low position, everything looks good. Open the curtain, make sure they have their call light, go wash your hands, and end your skill. No documentation for this particular skill. Not necessary. So the next skill goes along with this one, and the next skill is emptying that drainage bag. So for the test, they're two separate skills. We do our opening skill, closing. Opening skill, closing. Two separate skills. I'm going to show you this video, but I'm going to go into drainage bag. I'm going to teach you about drainage bag first, and then I'll show you these two videos, one right after another. Because in a clinical setting, they do go together. When you do catheter care, you're going to empty the drainage bag. But for the test, they're two separate skills. Good? All right. So let's go to page 164 and talk about drainage bag. And then I'll show you both of these videos. So if you look at the sidebar here, you'll see that we're going to read the care plan, do our opening, wear gloves. We need a barrier. We're going to clean the basin and do our closing. We know how to do all of those things. There's nothing new to learn there. They're all spelled out for you here. For those of you who need a refresher, I do have a video for it. And down here, you can see our test info. Somebody with your level of experience should be able to empty that bag in 9 minutes or less. Way more time than you need. The video takes 3. They give you way more time, than you need. This is going to be done on a mannequin. Mannequin will be laying in bed. Charting is required. And you have to be accurate within 50 cc's of the evaluator's reading. So the evaluator is actually going to measure the urine as well. And you've got to be within 50 cc's of what her reading is. Okay. So if you look on page 165 at the top, you'll see the care plan tells us to empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. And you can see that form right here. Again, on page 169, it will have a full size form for you as well that you can play with. I think it's 169. Yeah, 169. All right. So there's different kinds of bags. We've talked about this, right? There's a bedside bag and there's a leg bag. Both of them connect to catheters. Doesn't matter what kind of catheter, both of them connect. Same port. What's different here, other than the amount that they hold, is how they're emptied. A bedside bag, where's my bag? Did I put it away? Yeah. So a bedside bag is going to have a port similar to this, and most of them empty through what we call a T valve. So this is the port here. It lives in a little house. You remove it from the house, and you slide the port to the side to open it. Now that port is open. You slide it back the other direction, and that closes. Okay, so those of you at home, the port lives in its little house. You see? We remove it from its house. And here you can see that it's closed. See that it's closed. If I slide the T-valve to the side, it opens it. We slide it back to the side, it closes it. And then we're going to put it back in its house. So that is a bedside bag, and that's what you see here. There are other different types of ports as well. Wherever you go to work, you're going to be trained on how to use the bags they use in their facility. There's millions of bags. Leg bags work a little bit differently. leg bags, the port at the bottom here is going to twist to open. So you just twist it, kind of like a soda. You just twist it. It doesn't come all the way off. You just twist it to open. After it empties, you twist it close. Okay. So little different mechanism, but both of them empty. When emptying the drainage bag, we want the graduate container placed on a barrier. Don't put the urine cup directly on the floor. That's not hygienic. And what if we spill? We don't want to, spill urine on the floor. So we're going to put it on the barrier. So for this skill, we're not going to use the table as our work surface because the bag is down on the floor. Remember, we can't lift the bag above the level of the patient's hips. So that is one of the ways that this skill is failed, is by lifting the bag up above the hips to empty it, or disconnecting the bag and taking it over to the bathroom. It's shocking how many students do that. Remove the bag from the catheter and take the bag to the bathroom. Don't do that. Remember that CNAs have to be trained to disconnect those two pieces. Make sense? Good? Okay. So we'll put a barrier on the floor, put our cup on the barrier, and when we go to empty it, that port, this port, cannot touch anything. It can't touch your gloves. It can't touch the cup. It can't touch the barrier. It can't touch the bed. It can't touch the outside of this bag. It can't touch anything, because anything it touches will transfer bacteria. When we're done, we want to very carefully put it back into its house, making sure the valve is closed. You don't want an open valve because that lets bacteria in. So make sure the valve is closed and then make sure it's in its house. When you go to put it in its house, you don't want to do this. Because you're contaminating that port with everything that's on this bag. Remember, the bag is close to the floor. Good? All right, so to open the T-valve, you just slide the button to the side. After emptying it, we slide it back. Don't touch the tip of the port with your gloves. Remember that that port can't touch anything. Nothing. All right, so let me tell you about the triangular graduate container. That's this guy. It's got a big name. Triangular graduate, because it has markings, container. This is what we put urine into to measure it. So this is going to have on one side ounces, on the other side cc's. What do we use in medicine? cc's. So just ignore the ounces side. Somebody on one of my videos said, oh, well, you can just measure it in ounces and convert it. It's already done. Why would you go through that trouble? Just use the cc side. Now, when you empty the urine into this container, it may not be exactly on a mark. You're going to round it to the nearest line. Up or down doesn't matter, just whatever's nearest. Okay? So let me pass that around. You guys can see how that works. But when we measure it, we have to make sure that we get it. There's 3 criteria here, and we have to meet all 3 criteria for credit. It's got to be on a barrier, on a flat surface, and we have to measure it at eye level. So I can't stand up here and go, yeah, it looks like about 450. It needs to be on a barrier, on a flat surface, and then I have to get down at eye level to measure it. Don't hold it up. Never put urine above your head. Don't hold it up, okay? But if you don't have it on a barrier, you don't get credit for any of this. If you didn't get down at eye level, you don't get credit for any of it. Good? We're going to document this on the documentation. This is output. Make sure you get it in the right spot, because this is your documentation form. It's going to have intake and output on it. Make sure you put it under output. Otherwise, you are certifying that this patient drank urine. This is a legal document. What do you think the lawyer's going to do with you? Okay. So you got to make sure it's in the right section. So time, military time is best. If you don't know military time, there is a lesson in the book on military time. But to me, military time makes way more sense than regular time. I mean, who was the idiot that said, okay, let's just go to 12 and then 13? No, let's just start over. Let's start over with 1. I mean, it doesn't make any sense. Why do we go to 12 and then start over at 1 again? How many hours are in a day? 24. Use them all. Use them all. So military time makes way more sense to me than regular time does. I mean, who was the guy that said, let's just start over, like right in the middle of the day? Let's quit counting and start over again at 1. Doesn't make any sense. So instead of 1, it's 13. Just keep going. 14, 15, 16, 17, 18, 19, 20, 21, 22, 23. And then when we get to midnight, it's the beginning of a new day. So it starts at 0. So you're just using all 24 hours. I've got a lesson in the book that you can use on military time. It's page 49. So we're going to put the time. If you use regular time, you can on the test, no problem. But you have to put AM or PM. You can't just put 11:58, or I'm sorry, 10:58. 10:58 AM or 10:58 PM, because healthcare works 24 hours a day. So if you're using regular time, make sure you're writing AM or PM. We're going to put the type of output, which is urine, how much we measured, and then our initials. So we're going to follow that care plan. We'll empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. We're going to do our opening. We'll use a barrier on the floor. We're going to wear gloves. We'll empty the bag into the container without letting it touch anything. Close the valve, put it back into its house without it touching anything. We're going to wrap the graduate with the chucks, because remember, you can't carry an open container of urine anywhere. Take it to the bathroom, put it on the seat of the toilet. We're going to get down at eye level and measure. So it's hard to see here. You'll see it in the video a little bit better. The video is actually going to have you measure this. And then we're going to empty the urine in the toilet, because that's where it goes. We'll rinse it, dry it, store it in the bottom drawer. Remove our gloves, do our closing, document, and then wash our hands again. Good? Any questions on that? No? All right, so for those of you tuning in at home, this is our triangular graduate container. You can see all of the ounces on this side, which we don't use, and the cc's or mLs on this side. And we're going to round to the nearest line. All right, so I'm going to show you both of these videos. And then once we're done with this, once we're done with these videos, we have one more skill to do, which is range of motion shoulder. It's going to take me 3 minutes to show you. That's it. And then after that, we'll take our break, and the rest of the class will be practice. You are now this close to being done with skills. All we have is range of motion shoulder, and we know how to do range of motion. We're just going to apply it to the shoulder. And that's it for skills. Look at you guys. You persevered. I'm so proud of you. So let's watch these 2 videos. Hold on one second. Madam, does the changing of the catheter and urine bag was generally weekly, or need to change as much as possible, especially when the patient has an overactive bladder? So where would we go to find information on how often that bag needs to be changed? The care plan, that's right. So there's no one answer that's going to fit everybody. We would go by the care plan for that particular patient. Thanks, Miss Patty. Last week I was in class and my lecturer was using your skills demonstrations for examples. I was very happy. Oh, thank you, Bunja. Vanessa says, how many times clean? 4 times. So 5 for the front. So the peri area, middle, side, skimple, 4 for the tubing. Go ahead and watch our videos.
Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to do catheter care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, Miss Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, a chucks, a privacy blanket, and now I'll gather my basin and soap. And a set of gloves. All right, Miss Jones, I'll just get some water. I'll be right back. Okay, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place the washcloths in there to stay warm. And I'm going to cover you with a privacy blanket. This is going to help protect your privacy and keep you warm while we do this skill. And I'm going to pull your sheet down to about your knees. Okay, Miss Jones, I'm going to place this pad underneath you. This is going to help keep your bed dry while we do this skill. First, I'll roll it toward me. And place it on the bed. And then I'll put my gloves on. All right, Miss Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. I'm going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the chucks underneath the patient's hip and have the patient come back onto their back, making sure that they don't lay on that catheter tubing. Miss Jones, can you scoot to the middle of the bed, please? Thank you. Miss Jones, can you scoot toward me? Thank you. And roll up onto your right side. 1, 2, 3. And now I can unroll the chucks to protect the bed. Come on back, Miss Jones, and scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and wring it out and apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we washed. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do peri-care. We'll take a washcloth out of the basin, wring it out really well, and we're going to soap 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first leaf, always going top to bottom. And then we'll remove the washcloth and fold that leaf over. Now I'm going to clean down one side of the labia, top to bottom, fold that leaf over, clean down the other side of the labia, top to bottom, fold that leaf over. I'm going to clean the skin fold between the groin and the leg, fold that leaf over, and clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll hold that catheter out of the way and spread the labia open, cleaning down the center, top to bottom. Fold that leaf over, clean down one side of the labia, fold that leaf over, rinse down the other side of the labia, fold that leaf over. We're going to rinse the skin fold, fold that leaf over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom and then removing the towel. Ms. Jones, I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor and not where the patient is laying on it, making sure it's not kinked. Ms. Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be cleaned the way we clean everything else. We'll return the basin to the drawer, and on the way we'll pick up the soap. We'll open the drawer with the paper towel and return the basin to its storage area. Now I'll dispose of my paper towels. Okay, Ms. Jones, I need to remove the chucks from under you. Can I get you to scoot toward me, please? Thank you. And can I get you to roll up on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Ms. Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the bed. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table, and we're going to throw this away, and then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Miss Jones, here's your call light. If you should need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like a magazine? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps in my skill, make any corrections that need to be made, and then tell the evaluator my skill is done. Okay. So somebody asks, I got a little confused. If I'm using the military time and it's 10:30, can I just leave it as 10:30, or should I also put at the end AM? And so I want to talk about this real quick. Military time, 4 numbers, all smushed together, no colon. Just 4 numbers. No AM or PM. So if it's 11:11, it's 1111. No punctuation, no AM or PM, just 1111. If it's 2:30 in the afternoon, it's 1430. So the 414. Remember, we don't stop at 12. We keep going. So 1 is 13, 2 is 14. So 1430. Okay. And I do have, if you have my book, I do have a whole lesson on that on page 49. There's a worksheet for you. All right, so let's look at the last video here. Oh, good question, Anna. Let me go through this real quick. So Anna says, can I first remove the chuck and then take care of the dirty supplies, or take care of the supplies first and then do the chuck? Doesn't matter. Doesn't matter. Whichever way you want to do it. Doesn't matter. We have 9 minutes to still. Video takes less than 4. Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to empty your urinary drainage bag. Is that okay? Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. For this skill, I'll need a barrier, which I'll place on the floor under the drainage bag. I'm going to need a set of gloves. And I'm going to need a triangular graduate container. I want to inspect the catheter tubing to make sure that it's coiled on the bed and the patient isn't lying on it and it's not kinked, but also that it's not hanging near the floor where somebody might get their feet tangled up in it and trip or accidentally rip the catheter out. This catheter looks like it's in the appropriate position. We'll now remove the port from its protective sleeve on the bag. Sliding the valve to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the floor. We can now fold the chucks over the graduate container for safe and secure transport to the patient's bathroom. Once we're at the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at eye level, and we're going to round to the nearest line, either up or down. You can see that the urine in this container is nearest to the mark of 425, so the amount that we will document is 425 milliliters, or cc's. Once we've measured it on a barrier on a flat surface at eye level, We can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down, use a paper towel to pick it up, paper towel to dry the outside, a paper towel to dry the inside. We'll discard this and then one for the drawer. We're going to place the graduate container in the bottom drawer and close the drawer with a paper towel. Okay, now I'll throw the paper towels away and remove my gloves. We'll throw those away as well. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? A magazine, perhaps? You have your call light there. If you should need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. After washing my hands, I'll document on the intake and output sheet that the evaluator gives me. I'm going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. After documenting, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right. Any questions? Any questions? Okay, if we can go to page 76, I don't have any on-screen graphics for this. Let's go to page 76. And this is range of motion shoulder. We missed this one on week 1. So we know what range of motion is. Range of motion are exercises prescribed in the care plan that helps us maintain a patient's current level of function. So remember, we're not trying to do anything to make anything better. There's 3 exercises we can do as CNAs. Flexion extension, which is up, down. Abduction, adduction, which is side to side. And rotation, which is around. So we'll put an opening in front and a closing in back. This is a very, very quick skill. The test says somebody with your level of experience should be able to do this in 4 minutes or less. So very quick. So if we look at the care plan at the top of page 77, it's going to tell us to provide the following range of motion to the resident's right shoulder, flexion extension and abduction adduction. It tells us to provide 3 repetitions of each exercise, and the resident is not able to help with the exercises. So this is pretty easy. We're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises. Is that okay? Close curtain, wash hands. And then we're going to make sure that we're on the correct side of the body, which in this case is the right arm. And we're going to bring the arm all the way up and then all the way back to the bed. We're going to do that 3 times. 2 and 3. And then we're going to bring the arm out to the side like you're making a snow angel. I always like to explain this in terms my patients can understand. If I go into a patient's room and I say, okay, now we're going to do abduction, adduction, they don't know what that is. And they're going to be afraid that it might hurt. So they're going to stiffen up and I'm not going to get a good range of motion out of them. So if I put it in terms they can understand, actions they're familiar with, I'm going to raise your hand above your head like you're asking a question. Everybody knows this is the universal I have a question sign. Everybody knows that sign. I'm going to bring your arm out to the side like you're making a snow angel. Even those of us in Florida that have never seen snow know what a snow angel is. Right? We make sand angels here, right? Snow angel. So I put it in terms my patient can understand. If I'm going to ask them to flex and extend their elbow, it's
make a muscle, rev a motorcycle, climb stairs. So I always make sure that I associate the action with a action that they understand. That way they don't stiffen up on me. So once I've done 3 of the abduction adductions, monitoring for pain, returning to start, slow and smooth, supporting at all joints from below, you know the drill. Then I'll do my closing, wash my hands, and my skill is done. Good. Questions on that one? I'll show you the video so you can see the whole thing in action.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
I'm great. I need to do some exercises on your left shoulder. Is that okay?
Yes.
I'm going to close your curtain and go wash my hands. I'll be right back.
Okay.
Okay, I'm going to do a series of exercises. We're going to repeat each one 3 times each. The first one's going to be a flexion extension where I raise your arm over your head and back down to the bed, and we'll do that 3 times. Is that okay?
Okay.
I'll do all the work. All you have to do is let me know if there's any pain or discomfort.
Okay.
I'll stretch your arm out here to start. So we're going to raise it above your head and back down to the bed 3 times.
Okay.
Supporting at both joints. We're going to go all the way up and all the way back down. Feel okay?
Yes.
Any pain?
No.
We're going to go up again and all the way back down. That's 2. 1 more. Up and all the way back down. That's 3. Feel okay?
Yes.
All right, your next exercise is an abduction adduction. We're going to swing your arm to the side and back in. We'll do this 3 times.
Okay.
Like you're making a snow angel.
Okay.
So we're going to go all the way up and all the way back down. That's 1. All the way up and all the way back down. That's 2. All the way up. Feel okay?
Mm-hmm.
And all the way back down. That's 3. Are you comfortable?
Yes.
Can I get you anything, such as a magazine?
No.
Okay, your environment is clean. Here's your call light. If you should need anything at all, please let me know. I'll go ahead and open your curtain. And there's nothing else that you need?
No, ma'am.
Okay, I'm going to go wash my hands. Thank you.
Thank you.
After washing my hands, I'll review all the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right, so that is the last skill. We do have a couple questions. These are good questions. And before I get to the questions, let me clarify something. When I did the care plan off the top of my head, I said right arm. Your care plan in your book actually says left. The skill was demonstrated on the left arm. Remember, we always follow the care plan. I don't know what the care plan for the test is going to say. Some of them say right. Some of them say left. How do we know? Follow the care plan. Yeah, read that thing. All right. Jabangle says, in the video, it looked like a little pee was left over in the bag. Is that okay when testing, or will they ding us? Yeah, absolutely. It's not Maxwell House. It's not good to last drop. So you won't get every single drop out. A little bit left is okay. You just don't want a significant amount. So a couple drops left in there, that's okay. You're not going to get it completely empty and dry. But you don't want to leave, 20 or 30 cc's in there. You don't want to leave enough that it's noticeable. So great question. Great question. And then Curtis says, wait, I have a question. We don't always measure in mLs. You should. The care plan specifically tells us to document in cc's or mLs. So we're going to follow that care plan, right? So because the care plan says cc's or mLs, that's what our facility requires. That's what we're going to do. You'll want to follow the care plan for your specific patient. But most of them are going to be
CCs or MLs because that's universal in medical. All right. So your homework tonight, and we're at that point already. Your homework tonight is chapter 10. It's a short chapter. It's on employability and stress management. It's not difficult at all. But you do want to read it because there's some good information in there for you as well. One final reminder, 2 p.m. is CPR. You'll be able to practice for the remainder of class. I told you about an hour and a half. We're right on time. And then those of you who need to leave can certainly do so. Those of you that are coming back for CPR, remember CPR is at 2. And remember on Wednesday when you come in, you're going to be returning the yellow book. So you need to bring that book back with you. And we will be taking a photo. So whatever you need to do to be on camera. So let me get you your review sheets for today for class 7. Those of you who are joining us online, remember those review sheets are also available on FL CNA training. So you can print them out and you have access to those as well. If we were helpful to you today, if you could give us a thumbs up or a heart or something, that lets everybody in YouTube world know that somebody found this helpful. And it'll help us be found a little bit better in YouTube's algorithm. So for those of you joining online, if you found this helpful, please give us something on YouTube to let YouTube know that we were helpful to you. All right, we're going to go ahead and sign off of the live. So thank you guys so much for joining us. Make sure you join us tomorrow at 11 a.m. for the game show. It'll be very helpful to you. And we'll see you on Wednesday for graduation. My next class doesn't start until July 22nd. So I've got 2 weeks off. So you won't have classes next week or the week after. I've got 2 weeks off. And I've got some big projects I'm doing. So tune in on July 22nd for the next class session. Oh, thank you guys so much. I truly appreciate it. My hearts. All right. Okay, we're going to go ahead and sign off. And until next time, happy caregiving. Bye.